Great. So this is going to be chapter 2, which is the skeletal system. These first few slides are going to be a recap of what you have already learned previously. So to start, there are 206 separate bones in the body. 126 bones are in the appendicular skeleton and 80 bones are in the axial skeleton. Bones are composed of mostly calcium and phosphate. The primary functions are body support, protection, movement, and blood cell production. There are different types of bone tissue. There is compact, which is the outer portion of the bone, and then on the inside there is the medullary cavity, which is made up of cancellous bone. The bone marrow is located within that cavity and is found between the trabeculae. It is like a webby design in there. The trabeculae are the trabecular markings that you look for to evaluate your images. Bone marrow is responsible for the production of erythrocytes, thrombocytes, and leukocytes. There are two different types of bone cells. They are osteoblasts and osteoclasts. Osteoblasts are bone-forming cells that line the medullary cavity, and they are found along the periosteum. They are responsible for bone growth. Osteoclasts are specialized cells that are responsible for bone remodeling. They break down bone to enlarge the medullary cavity and allow for bone growth. Bones are classified into different categories, and they are long, short, flat, irregular, and sesamoid bones. Bones have three different portions called diaphysis, epiphysis, and metaphysis. The diaphysis is the shaft portion and primary site of ossification. The epiphysis refers to the expanded end portion of a long bone and is the secondary site of ossification. Metaphysis refers to the growth zone between the epiphysis and the diaphysis. There are three different types of joints in the body. Your fibrous or synarthroidal joints are firm and immovable, like the sutures of the skull. The cartilaginous or amphiarthrodal joints, which are slightly movable, like intervertebral joints. The final joint would be synovial or diarthrodal, which are freely movable, like your knee. When you are imaging the skeletal system, there are different imaging modalities to consider. Radiographically, you want to be sure that you are using the proper technique. It is important to be using the proper technique for achieving an accurate diagnosis. You want to see trabecular markings on the bone adequately penetrating the soft tissue, and if your patient moves, you don't want motion in your image because it lowers the quality of the image. MRI is useful in identifying skeletal pathology, especially when it comes to soft tissue. MRI has great contrast resolution that is great for detecting and staging soft tissue tumors. MRI is most commonly used to examine joints. Next is CT, which is a quick and non-invasive way to examine the skeletal system. CT can identify fractures in detail of the fractures or dislocations. They can assess abnormalities in joints as well as soft tissues. Nuclear medicine has the ability to look at the entire body at one time and provide information on it if a pathology is an old injury or a new one. Nuke Med is also utilized in examining metastatic processes because it demonstrates metabolic reactions of the bone to the disease process. We are going to start looking at diseases that are classified as congenital and hereditary. Osteogenesis imperfecta is also referred to as brittle bone disease. It is a serious but rare disease affecting the connective tissue. It's commonly the result of an autosomal dominant defect. It is classified as 8 types, 1 being the mildest and 8 being the most severe. It is also called OI. So OI is caused by mutations in 2 structural genes that make up the main collagen of bone, tendon, and skin. It is separated into 2 main clinical groups based on age of onset and the severity of the disease. Osteogenesis imperfecta congenita is present at birth. Infants with this disease usually have multiple fractures at birth that heal only to give way for new fractures. This results in limb deformities and dwarfism, and may lead to death. Osteogenesis imperfecta tarda appears a few years after birth and generally stops once adulthood is reached. The radiographic appearance of OI shows the multiple fractures in various stages of healing, and it'll have a general decrease in bone mass. The bone cortex is thin and porous, and trabecula are thin, delicate, and widespread. So you can see that by the pictures that I have on the side here of OI. Achondroplasia is the most common skeletal dysplasia. It results in bone deformity, decreased bone formation, and disproportionate dwarfism. It is caused by the autosomal dominant gene at the 4p chromosome location, and this gene does not skip generations. People with this disease have a 50% chance of passing it on to their children. Individuals with this disease will have a normal trunk size but have shortened extremities due to the long bones not being able to grow in a normal manner. The cartilage in the epiphyses cannot convert into the bones as it normally would, so that is why the extremities are shorter than they should be. Other manifestations include kyphosis, hyperlordosis, spinal stenosis, bowed legs, a bulky forehead with midface hypoplasia, and narrowing of the foramen magnum, which causes neural compression. Treatment for achondroplasia may include orthopedic surgery. The Ilizarov procedure has been used in an attempt to lengthen the shortened limbs. Otherwise, growth hormones can be given to children at an early age to try to treat the disease. However, it could have adverse effects to the cardiovascular system, so that is a risk that would be taken for that treatment. This can possibly be seen on ultrasound for prenatal diagnosis. To monitor this, radiographic studies of the left hand are taken and analyzed using the Atlas matching method or the point scoring system of Tanner and Whitehouse. Osteopetrosis and marble bone disease are terms that describe a variety of dysplasias involving an increase in bone density and defective bone contour, which is often referred to as a skeletal modeling. These are mutations in at least 9 genes caused by the various types of osteopetrosis. 75% of the cases are a result from the mutation on the CLCN7 gene. Disorders that are classified under osteopetrosis are osteosclerosis, craniotubular dysplasia, and craniotubular hyperostosis. This is important for technologists to know because osteosclerosis and craniotubular hyperostosis are additive diseases, which means we should increase our technique to get proper exposure. Radiographs will show an increase in the density and the thickness of the cortex and an increase in the number of the size of the trabeculae with marked reduction in marrow space. This picture is an example of osteopetrosis of someone that has fallen out of bed. Now we're going to move on to hand and foot malformations. Many hand and foot abnormalities can occur during the fetal development, but they can be surgically corrected at birth. Syndactyly is the failure of fingers or toes to separate. The result of this is that it creates a webbed digit appearance. It is mostly associated with Apert syndrome, which involves mutations of fibroblast growth factor receptor 2. Polydactyly refers to the presence of extra digits. Treatment of this would be surgical removal of those digits and then therapy. Clubfoot is also known as talipes, and it is a congenital malformation of the foot that prevents normal weight bearing. This is more commonly found in males, A clubfoot is generally corrected by casting or splinting the foot in the correct anatomical position. Development dysplasia of the hip is also known as DDH. This is the malformation of the acetabulum. Because the acetabulum is shallow, the head of the femur is displaced superiorly and posteriorly. Generally, the ligaments and tendons responsible for proper placement of the femoral head are also affected by this disease. A risk for DDH is a fetus being in the breech position, being the first child, or low levels of amniotic fluid during gestation. DDH can be associated with cerebral palsy, myelomeningocele, arthrogryposis, and Larsen syndrome. Early diagnosis and treatment are critical to provide the best functional outcome for the baby. Sonography can also be used to diagnose this anomaly through visualization of the cartilaginous structures of the hip. Radiographs are often difficult to interpret on a newborn, but radiographic measurements of the AP pelvis and the bilateral frog leg views are obtained and compared with standardized lines. DDH should be treated with immobilization through casting or splinting the affected hip to allow the development of the femoral head and acetabulum and the formation of the functional joint. So here you can see that the left hip is displaced in this image. Now we are going to talk about vertebral anomalies. Scoliosis is the abnormal lateral deviation of the spine, and it usually includes vertebral rotation. Scoliosis usually does not become visually apparent until adolescence, and it affects more girls than boys. A few complications of scoli can be cardiopulmonary complications, degenerative spinal arthritis, fatigue, and joint dysfunction syndromes. Radiography is very important in diagnosis and treating scoli. Primary evaluations require initial AP or PA and lateral standing imaging, and follow-up imaging to monitor and evaluate the progression of the disease. It is important to shield the breast of a young female during the radiograph to reduce radiation dose. Spina bifida is the failure of the lamina to unite posteriorly, resulting in an incomplete closure of the vertebral canal. It is common to find spina bifida in the lumbosacral area. The severity can vary from paralysis to no visible abnormality or neurological deficit. Treatment is based on the extent of the anomaly and requires the services of a variety of healthcare providers. Craniosynostosis is often associated with Apert syndrome. This disease is congenital premature closure of one or more of the cranial sutures before the brain is fully formed. When this happens, it alters the shape of the head, so the cranium continues to grow in the areas of the skull where the sutures remain unfused to accommodate brain growth. This can be corrected with surgery, but it does have a risk of brain damage. Encephaly is a congenital abnormality in which the brain is underdeveloped and the cranial vault is incomplete. In most cases, only facial bones are formed, and this abnormality results in death shortly after birth. It is a neural tube defect and can be diagnosed before birth by sonography. Now we are going to move on to inflammatory diseases. Osteomyelitis is an infection of the bone marrow and surrounding bone caused by a pathogenic microorganism spread by the bloodstream. Signs and symptoms may include dull pain, heat, swelling, and redness in the affected area, and varying degrees of fever. Hematogenesis osteomyelitis generally develops at the end of long bones and is most commonly affecting infants and children. Infants are more susceptible to E. coli, and children are more susceptible to staph infection. Adults can also be affected by hematogenesis osteomyelitis, but it is more commonly affected in their vertebra. And it is generally a secondary infection caused by bacteremia in the genitourinary tract, soft tissue, or respiratory infections. Osteomyelitis resulting from contagious infections often associated with burns, sinus disease, periodontal infection, soft tissue infection, or skin ulcers resulting from peripheral vascular disease. Pathogenic microorganisms may also be directly introduced to bones by penetrating wounds, open fractures, fractures treated with internal fixation devices, or prosthetic replacements. Osteomyelitis can be diagnosed through lab testing that shows an elevated ESR or CRP level. Radiographically, osteomyelitis may demonstrate soft tissue swelling in the area of interest, but is not the best modality to utilize in this case. Nuke Med and MRI are better equipped to detect acute and secondary osteomyelitis. Bone and joint tuberculosis is a chronic inflammatory disease caused by Mycobacterium tuberculosis. This infection is typically secondary to pulmonary TB. Most commonly affected are the hips, knees, and spine. Radiographically, the long bones display a worm-eaten appearance, with the disease slowly destroying the epiphysis. TB in the spine is also known as pot disease because it destroys the spine by causing softening and eventual collapse of the vertebrae. Arthropathy is a collective term that describes inflammatory diseases in the joints. Examples are arthritis, bursitis, tendinitis, and tenosynovitis. Infectious arthritis or septic arthritis is caused by a variety of pathogens. The infectious agent can enter the joint by a break in the skin, with common symptoms including a rapid onset of pain, redness and swelling of the injected joint along with the fever. It is diagnosed initially with lab tests and testing synovial fluid of the affected joint. Radiographic changes will show soft tissue swelling and joint effusions, with joint space narrowing that is only visible 2 weeks after the infection. Radiographs are taken during the healing process and they will show recalcification and sclerosis of the joints. Treatment is typically antibiotic therapy. Psoriatic arthritis is an inflammatory arthritis associated with psoriasis of the skin and involves a rheumatoid-like destructive process that affects the dip joints of the hands and feet. Radiographic findings include bony ankylosis of the IP joints of the hands and feet and resorption of the terminal tufts of the distal phalanges. A distinctive difference between psoriatic arthritis and rheumatoid arthritis is that psoriatic arthritis bone density is usually preserved and RA is usually destroyed. Rheumatoid arthritis is a chronic systemic disease primarily of joints characterized by overgrowth of synovial tissues and articular structures and progressive destruction of cartilage, bone, and supporting structures. Genetic factors are also believed to be a predisposing factor if an individual may have RA. It is diagnosed during an analysis of blood chemistry, and it'll identify the presence of an autoantibody known as serologic rheumatoid factor, or RF. It is 3 times more likely to occur in females and occurs between ages 30 and 40. Symptoms include pain, swelling, and stiffness of the affected joint. Initially, RA appears radiographically as soft tissue swelling and osteoporosis on the affected bones. As it progresses, the joint space is narrowed due to critical erosion and the overgrowth of the synovial tissue. Severe damage makes the joints unstable and can cause displacement. So when the joints become ankylosed or fused together where surgery is needed, the American College of Rheumatology and the European League Against Rheumatism created this criteria to identify patients earlier so intervention can begin sooner. The criteria involves having synovitis in at least one joint, having an absence of an alternative diagnosis that better explains synovitis, 6 or greater domains of the number and site of involved joints, and a serologic abnormality, evaluated acute phase response and symptom duration. Juvenile idiopathic arthritis is also known as Still's disease, and it affects children under the age of 16, and it is similar to the adult form of rheumatoid arthritis. Symptoms include pain, swelling, and stiffness, with periods where symptoms are present and not. So the symptoms go into remission for a while, which is very common. It can go into remission for a fairly long time. The ACR criteria involves the patient needing to be younger than 16 years at the onset of the disease. Symptoms of arthritis are present in one or more joints for at least 6 weeks. The onset can be assigned to one of several JIA onset types. Those include oligoarticular, polyarticular, systemic, and enthesitis-related arthritis. So these are pictures that demonstrate rheumatoid arthritis with subluxation of the first MCP joint. Reader syndrome is another inflammatory disease that is a variant of RA and occurs most commonly in young males and is associated with arthritis. It has been associated with bacterial infections. SI joints, calcaneus, and toes are all generally affected by the disease and are sometimes referred to as the lover's heel. Nuke med can be beneficial in diagnosing the disease, and the treatment is using over-the-counter NSAIDs. Ankylosing spondylitis is referred to the Murray-Strumpel disease. It is a progressive form of arthritis resulting in the chronic inflammation of axial ligaments characterized by initial laxity and progressive ankylosing, which mainly involves the spine. Eventually, the spine actually fuses together into a rigid block of bone, and when it is fused in that shape, it gives a condition from the look, and it is called bamboo spine, which is what I have these pictures looking like over here, like bamboo. Early signs and symptoms include a low-grade fever, fatigue, weight loss, anemia, low back pain, and morning stiffness. Radiographically demonstrate bilateral narrowing and fuzziness of the SI joints. The spine will be calcified and there will be ossification of the vertebral ligaments, giving off the impression of the bamboo spine. So like I said before, you can see that from the pictures here. They're looking like bamboo in the spine. Another way to test for this is blood serum analysis, and treatments for the disease are NSAIDs, therapeutic exercise, and postural training. Osteoarthritis is a disease of the cartilage and is the most common type of arthritis. It is also known as degenerative joint disease, or DJD. It affects men and women equally, but symptoms don't appear until people are in their 50s. Osteophytes are bone spurs that appear on radiographs and are indicative of osteoarthritis and helps distinguish it from other types of arthritis. In addition, the bone spurs, the joints, are also going to appear narrow on the radiographs. You will also notice with the osteophytes that they are called Herbarden nodes and Bocard nodes. They are bony knobs that appear on the dip and pip joints. Treatments consist of NSAIDs, COX-2 inhibitors, and acetaminophen. Exercise can also decrease the pain and increase flexibility. So I have 2 images that display osteoarthritis here. Gouty arthritis is an inherited metabolic disorder with excessive amount of uric acid produced and deposited in the joint and adjacent bone. It is most commonly located in the MTP joint of the great toe. It occurs more frequently in males and results from a combination of genetic, constitutional, and environmental factors, and may occur in patients placed on long-term diuretics. The crystallization of the uric acid with the joint causes an acute inflammatory reaction, so the large masses of those crystal deposits in joints are called tophies. Treatment of gout consists of a lifestyle modification and medications either to promote excretion of uric acid by the kidneys or to inhibit the production of uric acid within the body. Tendinitis is inflammation of a tendon, and inflammation of the tendon sheath is known as tenosynovitis. Bursitis is the inflammation of the bursa of the tendons, with the subdeltoid bursa as the most common site. A ganglion is a cystic swelling that develops in connection with the tendon sheath or joint membrane. Radiographs and MRI are the modalities of choice when evaluating inflammation regarding the joints. Treatments can include NSAIDs, removing accumulated fluid, corticosteroid injections, and possible surgical intervention. The final classification that we are going to talk about are the neoplastic diseases. There are many varieties of bone tumors. However, primary bone tumors are more common in children and metastatic bone lesions are more common in adults. The most common benign bone tumors are an osteoma, osteochondroma, and the giant cell tumor. The primary malignant bone tumors are osteosarcoma, Ewing tumor, and multiple myeloma. In order to diagnose a bone abnormality, it is often made radiographically based on the individual's age, the pattern of the bone destruction, the location of the tumor, and the tumor's position within the bone. Imaging plays an important role when diagnosing and managing tumors. Radiographs can be used to identify lesions and show growth characteristics that help determine if a neoplasm is benign or malignant. CT plays a key role in initially diagnosing the patient as well as continuously monitoring the progression of the disease. Bone scans are beneficial because they can demonstrate the metabolic reaction of the bone to the neoplastic disease process. MRIs are important because they can evaluate the bone marrow and tissue to evaluate if there is any abnormality in the bone. The staging system for bone tumors, both benign and malignant, was developed by Enneking in 1980. So in this system, benign tumors are staged using Arabic numbers, and the malignant tumors are staged using Roman numeral numbers and include histologic grade, extent of the tumor, and the presence of the metastatic disease. An osteochondroma is a benign tumor of adult bone capped by cartilage. It is the most common benign bone tumor and is slightly more common in males than females. The cortex of osteochondromas blends in with the normal bone, and the growth, called the exostosis, tends to protrude up and away from the nearest point. Osteochondromas are often asymptomatic and have an osteoblastic and osteosclerotic radiographic appearance. CT and MRI are used in initial differentiation between an osteochondroma and a malignant lesion. An osteoma is a less frequent benign growth, most commonly located in the skull. An enchondroma is a benign growth of cartilage arising in the metaphysis of a bone. It's an aggressive tumor, but it is not invasive. It expands in the cortical bone, causing thinning, so radiographically, it has an appearance as a small radiolucent lesion containing small stippled calcifications that have sharply defined margins. CT and MRI are beneficial in distinguishing between enchondromas and chondrosarcomas. Osteomas and osteoblastomas have similar histology, but they differ in many other ways. An osteoma is smaller than 2 centimeters, involves the spine, is not associated with any bony reactions, and often no pain is associated with them, and they are an osteolytic lesion, whereas an osteoblastoma is larger than 2 centimeters, involves the femur, tibia, or spine of a young adult, may have extreme pain, and appear radiolucent area with a dense center, which is referred to as nidus. Giant cell tumor are locally aggressive, rare neoplasms characterized by the presence of numerous multinucleated osteoclastic giant cells. Giant cell tumors are also referred to as an osteoclastoma. A GCT can either be malignant or benign and is more commonly found in women than men. Radiographically, the mass of the cystic area being surrounded by a thin shell of bone gives this soap bubble appearance. An osteosarcoma is a primary malignancy of bone, usually arising in the metaphysis, most commonly around the knee. It is the most common malignancy except for myeloma. It arises from osteoblasts and the cause is directly linked to the deletion of genetic material on chromosome 13. The genetic instability allows for the development of sarcomas, so the radiographic appearance of an osteosarcoma is a sunburst or sun ray appearance due to the tumor growing from the metaphysis and lifting the periosteum from the cortical bone and laying down spicules of new bone. Osteosarcoma is a highly malignant disease with a poor prognosis due to lung metastasis. Ewing sarcoma is malignant bone tumor occurring between ages 5 and 15 and is most common in males. It arises from the medullary cavity and involves bone more diffusely, giving rise to uniform thickening of bone. It is extremely malignant. Clinical symptoms are nonspecific but often mimic osteomyelitis. MRI, CT, and radiographs are all essential in establishing the disease. The lesion undergo a combination of bone formation in the early stages and destruction in the later stages. As new bone is formed on the surface, it gives the appearance of an onion skin or laminated appearance radiograph. A chondrosarcoma is a malignant tumor of an atypical cartilage. It is less common. Less than 10% of malignant skeletal tumors are a chondrosarcoma. They may be bulky and have a tendency to destroy the bone as they extend through the cortex into the surrounding soft tissue. They are most commonly found on the pelvis, shoulder, and ribs. Radiographically, it shows irregular or circular radiolucencies in combination with granular areas of calcification. They tend to be larger in size than what is shown radiographically. Neither radiation therapy or chemotherapy are particularly effective for this as a treatment. Most commonly, what happens is a major surgery, like an amputation or a chest resection, to get rid of the affected area. When this is done, it tends to have a year's survival rate of approximately 40%. Metastatic diseases from carcinomas are the most common cause for malignant tumors of the skeleton. Bones containing red bone marrow are most often affected, with the spine and being most common. Certain characteristics help distinguish between primary and secondary malignant neoplasms. The periosteal response is much more common with primary malignant tumors. Soft tissue masses are common in primary tumors and rare in mets and lesions that are longer than 10 centimeters, often represent a primary malignant tumor. Those are all characteristics to distinguish between primary and secondary. The most common types of cancer to spread are breast, lung, prostate, kidney, thyroid, and bowel, with the cancer spreading through the bloodstream or lymphatic system. Alright, so this is the end of chapter 2. I don't have a conclusion slide on this one. We have reviewed and learned a lot of information, so I want you all to just take it all in. This week is probably going to be a lot, just jumping back into everything. But thank you for your time and everything.